Hi, and welcome to Faculty Focus, a podcast supporting the clinical education community in Leicester. We bring you Educator CPD, showcase new initiatives, and shine a light on some of the faculty behind it all.
Right, hello and welcome to the Faculty Focus podcast. Today's episode, we're going to be talking all about the GMC National Training Survey, what it is, when it's done, and why is it important. The reason we're doing it now is actually quite timely because the GMC survey for 2024 has just been released online. And those of you who work at UHL in any sort of education leadership roles may well have received an email from the guest joining me today, letting you know what your results are for your areas. So I'm going to let Joanne introduce herself. Joanne.
Hello. Thanks for inviting me, Andy. So I'm Joanne Kirtley, Head of Medical Education Management at UHL, so working with the Director of Medical Education in the education team.
Great. So this must be a very busy time for you then, given that you've sent me the ITAPS results. I'd imagine you've done something similar for everyone else already.
Not everybody else yet, because I've only had 5 days, so just working my way through the different results and then sending them out. I just thought it was probably a good idea to get yours out before we met this morning. So you jumped the queue a little bit, but I'm about halfway through at the moment.
Got the special treatment. That was very nice to know. Just the GMC survey, just a bit of background really for our listeners. It's an annual survey that's done, administered by the GMC. It's sent out to all doctors in training in the UK. It also is sent out, or it's not mandatory as such, but it's also, the trainers are also invited to complete their own survey as part of this overall process. It's usually done in April, May. In fact, it closed on the 2nd of May this year. And then it takes a little while for the GMC to process all that information and then publish that information using an online tool. So it doesn't come out as a sort of PDF document. It comes out as an online platform, a database, which you can then sift through and click what things you're interested in, and it can give you some information at the end of it. So why is it done? Joanne, do you want to tell us why these sorts of surveys are done and what we do with them?
Yeah, so actually for the Trust, the GMC survey work starts when the survey, quite soon after the survey opens. So as part of the survey, trainees are able to raise concerns about patient safety, and they're able to also highlight any bullying or undermining that's taking place. And they can do that as a free text comment. Those free text comments are shared by the GMC with NHSE, and the Trust, they're categorised into 3 different sort of levels of concerns. If it's deemed as an immediate patient safety concern, the Trust are notified immediately and are asked for an immediate response. And you won't know about that unless you get one of those. And this year, I think we had two that required an immediate response. So that happened back in May, and the service in question was asked to respond, and then we send that response back to NHSE to share it with the GMC. That's completely confidential. We won't know which trainee has raised that, and we will know which area. The second category of those concerns is that Trust need to respond, but it's not urgent. And so they come through to us towards the end of May when the survey's closed and all the comments have been collated. And we had a handful of those this year, which were returned to NHSE in July. And then the third category is it's for Trust information only. So sometimes it's a very vague comment, or it's something that NHSE know is already in hand, and we just have that for information only. So that process is going on in the background as soon as the GMC survey opens, and the Trust is responding to concerns according to which category it comes into. So that's already happened before the results, and the reporting tool is actually opened.
Right. Okay. So yes. So there's a kind of urgent and things that are really important and urgent need dealing straight away. It's almost unethical, if you like, to leave it till however many months later for the results. So
that's if it's deemed a patient safety concern or immediate risk, then we're asked to respond within a very short turnaround time. So we usually have about a week, 10 days to get a response from the service. Those responses are sort of shared with the senior management of the trust, and then we respond back to the NHSE. But I say it's completely anonymous all the way through. So there is an option to ask if the trainee could provide more details, but that we don't. That's not really very encouraged at all. So every now and again, we've thought it'd be really helpful if we could just have a little bit more information so that we can, give a sort of more informed response. But they're not very keen on that because obviously from the trainee's point of view, you would want to be reassured about your anonymity.
Okay. And you mentioned NHS England being involved in that process. So you're not communicating directly with the GMC then, you're going via NHSE as the
yes, sort of that's right.
The one that commissions education.
NHSE are sort of the gatekeepers. So when the survey results come out, so I don't know if you asked me a question that I haven't answered about why is the survey done and what is it? Maybe I've skipped that. Sorry.
No, that's all right. Go for it.
No, I was just going to finish off about the role of the NHSE, the GMC and the trusts, really. The NHSE are sort of the gatekeepers of the data. So they see the outcomes of the GMC survey before we do, and then they send us our breakdown of results for us to sort of have a look through. But at the same time, as soon as they've done that, we know we can access the reporting tool. So I tend to go into the reporting tool alongside looking at the NHSE outcomes.
Yeah. Okay.
Just to get a bit more detail.
Sure. Yeah. And yes, you mentioned just a second ago that, why is it done? Why is it important? So I remember being a trainee and then feeling certainly it was a way of being able to provide some sort of comprehensive feedback around the whole experience in training. So that was my perspective when I was a registrar. Are there sort of other elements to that as to why it's done? Is it useful? Is it something you can kind of use?
I think it is. The GMC survey has been going for many years, and so there's a lot of historical data there. There's a lot of information that you can look at trends. It used to be mandatory, I think, but it isn't anymore. I think this year there was a 76% response rate nationally. I think some programs make it an ARCP requirement. Other programs just emphasise the importance of people doing it. And so you mentioned, I think, or you were going to mention that there's a trainer survey as well as a trainee survey. The trainer survey isn't mandated in any way, and the return for this year, I believe, is sort of mid 30%. So it tends to be about a third of trainers will respond to the survey and 2/3 don't. And that seems to be a sort of a national figure. I think we're quite in line with that.
Yeah. And I think over the years, there's lots of other surveys as well that have kind of joined on. And those are probably other things that you get involved with too. So what other things?
So the GMC survey is obviously the regulator survey, long-standing, only available for doctors in training. It's not available if people are on maternity leave or have taken an out-of-programme break. So it's only accessible to people who are sort of in an active training post. So that isn't available to trust-grade doctors either. The other survey that's been going for the last couple of years is NHSE's own survey. So the commissioners, they have the NETS survey, and NETS takes place in the autumn, and that's the National Education and Training Survey. So that takes place in November time, and we usually find the results out from NETS in the spring of the following year. There's quite a lag with NETS to get the data. And NETS covers all learners in the healthcare setting. So that will include student nurses, physios, pharmacists, anybody who is in sort of a learning role. And that includes undergraduates as well. So that's medical students as well. Right. This year, the response rate was better, but it's still not as good as the GMC survey. But again, from a doctor's point of view, it's only trainees.
Yes, okay. Because actually the surveys seem very similar in terms of the questions they ask. And I get, that's something that I hadn't quite appreciated, is that just the range of respondents in that survey is that much greater, isn't it? So yeah.
Yeah, and I think as with any survey that's online and has a reporting tool, there are things that the GMC's reporting tool does really well and things that the NET survey reporting tool does really well. I think my experience so far is that the GMC has more capability of drilling down into detail than the NET survey. That NET survey, you try and explore things, and then you just come to a bit of a dead end where you can't actually get any more detail. Obviously, there's always that sort of element of preserving anonymity in a small number of respondents, but even with big number of respondents on NET survey, there's some frustration at times that you can't actually see what it means, just get a number or a colour or something.
Yes, that's right.
Yeah. And then the other survey is the UHL survey, which we've been running now for about 8 years. And we run that in February each year, and that's open to all doctors in UHL at a sort of a training level, but it includes trust grades and trainees. And it also, unlike the other 2 surveys, allows free text comments for every question. And sometimes the detail in the free text comments is really helpful. But our response rate has gone down really low in the last couple of years. And I just think people are overwhelmed by the number of surveys that they're being asked to do. So I've got a bias towards the UHL survey because we try and use that a lot within the trust. But I do understand survey fatigue.
Yeah, I think you're, just coming back to your point about the drilling down into the information so we'll put the link in the show notes about the GMC and how you can access that online reporting tool. But, it can be quite overwhelming when you first see it because there's so many boxes to tick. But actually, it's quite straightforward. It's essentially a database that you select what you want to look at. But I think you're right. You do end up with a percentage number in a box on a table, and then it's color coded. And, you want the color codes not to be red or pink, and you want them to be sort of white or green. And that's kind of where it stops. And I think if there's anyone listening who's in an education leadership role, that can be quite frustrating, as you say. And so you almost have to have some other way of getting more qualitative information from your group of doctors in training that are with you, because otherwise it can be really, some of the questions it can be hard to apply them in different training settings. Different specialties have different setups. So the questions are interpreted in different ways. And also, certainly what I found, when I think that this particular category in the survey, if you've got a low mark, the questions can be stuff that's nothing to do with your actual CMG. So there's not, as an education lead, I can't actually affect, the libraries and facilities.
No, and I think that one of the indicators on the GMC survey is facilities. And we spoke about this last year, because facilities, when you actually look at the questions, is about access to the internet, access to the library services and Wi-Fi, and it's not about access to rest space and office space, which is a natural assumption that that's what facilities means. So sometimes the questions the indicator titles can be a bit misleading.
Yeah. So I think there's definitely a case for, people in those education leadership roles to try and develop their own way of getting more information, whether it's informal chats with trainees on a regular basis, if you've got a small number of them, or perhaps running your own exit discussions, exit interviews, that when people rotate out, they're probably in a position to tell you things, be a bit more honest about their experience.
Absolutely.
And that's something we're sort of the college tutors are trying to do in ITAPs. But if you don't have that, it can be very difficult to respond. When you get that email saying you've got red flag in overall experience, for example, which is an incredibly broad category, what do you do with it? And the first response, I'm sure you've had the response, which is, have you got any more information about that red flag?
That sounds good. And I try and offset that. So I have just sent a report out to somebody, and I have attached to it they had 5 red flags, so I have attached to it the questions for each of the red flags so that they can have a look at them, because otherwise I know I'd just be waiting for them to come back and ask me, have I got more information? So I try when I can to sort of provide that detail, anticipate the questions that are going to come. But as you can imagine, there's a huge amount of data to sort through.
So, it sounds like, certainly from an education point of view, this is this is the big indicator, if you like, the big mark that you are scored by nationally. So from an education point of view, from the Department of Education, it's quite an important survey. Is that something you see reflected in all the other areas of the hospital? You know, do people take this stuff seriously, or do they tend to just...
Yeah, I think it's just it's the survey that everybody knows about. So people tend to know that at this time of year, all those survey results will be coming out. But I think, picking up on your other point, it's only one indicator of things going on. We have CMG education leads across the trust in all areas who have their fingers on the pulse for most things. So when we have a negative outcome on the survey, it's often people are already addressing the issues because they're aware of them. So, and also working with the education leads, sometimes we can manage to help them resolve issues so that they don't actually show then on the GMC survey because we've managed to resolve them. So I think it is just one snapshot in time, really, but it is the one that everybody knows about. So it's the one we all look out for.
I mean, I'm conscious we have been
work of comparing ourselves to other trusts and to other programs.
Yeah, well, that's probably worth just spending a couple of minutes talking about. So that's the other side of what you do then, is you look at how we perform regionally with other trusts then, and I hadn't realised that also happens. So.
Yeah, so I know you're going to put a link in on the report to the reporting tool. So it's open access, so it's it's in the public domain. And I would say if anybody on the call wants to log into the reporting tool and have a look, first thing I do, which is what I do every year, is just watch the video on how to interrogate the reports. Every year there's a slight change. This year I picked up 2 changes, which I would have probably been trying to find my way to various bits and pieces. So I definitely recommend. It's 5 minutes, really helpful little video, and then you sort of gives you a head start on which report you're looking at, and knowing what you're looking at is probably one of the key things to the GMC survey.
Yeah, I think that's right. Well, I know I got quite frustrated last year with the GMC survey, and the reporting tool was not the easiest, and it took forever to load. And I think I wasn't alone in that, and it feels like the GMC have obviously put a bit of money into the behind the scenes bit of the.
Yeah. I've had years where it's actually sort of been. I've had a week of it crashing on every different browser I've tried to access it on, and as you can imagine, if I'm trying to get the results out in a really timely way, it's really frustrating. But this year I've had no problems at all, so presumably they improved that side of things.
Yeah, I think they've done a good job. It's certainly more accessible and quicker. That's the big thing, really, isn't it? So it doesn't take 5 minutes to load up your data. So I'm conscious we've talked a lot about sort of negative red flags and things like that, but that's probably where a lot of the focus is when you get these surveys back. Obviously it'd be great if I tell you what, let's talk about the color codes, because what they mean. So there are red and green flags, and then there's white. So if you're middle of the pack, you're white in terms of the scoring. What's it benchmarked to? It's benchmarked to that particular program, or that's...
So the GMC has indicators. So there are a number of indicators, starting with overall satisfaction at the top of the list, with facilities at the bottom of the list. So there's a list of indicators. Each indicator behind it has a series of questions. The questions are all assigned a score. And so you go on to the questions relating to clinical supervision. You might have 3 or 4 questions. You answer the questions. It's usually a Likert scale. You answer the questions, and then the average of your responses is the indicator score.
Right.
So all the trainees who are answering for that particular report group, that will be the score that appears in that box. So the score is out of 100. It's divided into 4 quartiles then. So if you're in the middle 50% of responses, then your score is in the intermediate quartile range. And therefore, when you look at the colours on the GMC survey, for each indicator, you'll see a number and it'll be a white box, no colour, if you're within the 50% in the middle. If you're in the lower 25%, then you will either be red or pink. If there's a confidence interval that the low score is a confidently low score, it'll be red. But if it's not confident, so if you've got a wide range of responses and they're not as confident that it's a bad score, it'll be pink. So, and it's the same going the other way. Very, very strongly green with high confidence level is a dark green. High score with a low confidence level is a light green. So when we're looking at the colour coding, the whites don't immediately need looking at inattention because they're within the 50% range. The reds do because they're confidently negative outliers. And the pinks tend to be areas to just keep an eye on. So if I see a specialty report that is pink across the board and every indicator is pink, but they've got no reds, I'd still think that was an area to look at more closely.
Right. Okay.
So that's what the colours mean. But I think also the numbers are important to look at as well. So if you are in the white, you've got a score of 80, that's in the intermediate quartile range. And then next year you have a score of 50, but you're still within the intermediate quartile range, then there's a trend there that's showing that things may be deteriorating. Again, that's the sort of thing I'd flag with the CMG leads and say, you've got no red flags, but your scores for study leave and your scores for local teaching have declined by quite a lot. So that might be an area to sort of look at. So yeah, numbers and colours, I think, are important to look at.
Right, that's right, yeah. And I think the other thing that's quite useful with that is usually when you get your results, when you go into the data, you're presented with usually several years worth of data. So you've usually got the previous 2 years as well. So you can see progress and trends, like as you said,
yes,
either with the percentages or the colours. Quite useful.
Help to look at the trend, yes.
Yeah. And a lot of people, certainly I've had some problems with type in the things you're looking for, the difference between programs and specialties.
Yes.
So this can cause a bit of confusion, it certainly has with me. So is there any sort of simple way of thinking about that?
I think this is the one of the key things where people do sort of have to struggle with the GMC survey. It's really important to know what you're looking at. And the data for the survey is taken from the NHSE. They provide information to the GMC. And every trainee will have a trust, will have a programme, and they'll have a specialty that they're currently working in. So they are the three things that are assigned to the trainee. So they can be part of the UHL group, they can be part of Foundation Year 1 group, and they'll also be part of whichever specialty they're working in at the time of the survey. Right. So if they're an F1 in cardiology, if you look at the programme report, you're looking at their F1 report. That's their programme. If you're looking at the specialty report, it's the specialty that they're working in at the time of the survey.
Right.
And I just think that word specialty is confusing because of the fact that we have specialty trainees.
Yes.
And so it's a really common error that people do a specialty report thinking that they're looking at their specialty trainee outcomes. And what they're actually looking at is if you do a specialty report for, cardiology, that just happens to be on to it. What you're actually looking at in the cardiology specialty report is all trainees in cardiology, GP, IMT, foundation and higher, all together, what's happening in cardiology as a department or a city. So, knowing whether you're looking at a programme report or a specialty report is really important. So they can look very different. If you've got one very happy group of trainees and one very unhappy group of trainees, put them all together and you've got the average.
Yeah, sure.
So I think that's a real take-home.
That's really important for any of those specialties. Well, there's pretty much all the specialties will have people rotating in and out at different parts of different programs, and that's definitely a mistake I've made before. Is I've just searched around, and if you've got people coming through doing 6 months of ITU as part of their medical training, or an ACCS doctor who's actually following an ED training pathway, that all gets muddled in together. So
that will be in your anaesthetic specialty report, because they will have a specialty as part of ACCS as intensive care medicine. So that will be part of the specialty report. If you want to see what your anaesthetic training are doing, you need to look at the anaesthetic programme report.
Programs, yeah. Well, that's really useful. And I'm sure you'll probably get a few emails coming back saying, but I've done the survey and I can see that it's all, there's no problems. And so that could lead to frustration. How do the survey results help bring about change? Because ultimately that's what it's kind of about, isn't it? So trainees, if they've reported that somewhere they're not particularly enjoying, or that there's a problem in that area of the hospital, how does that end up?
So results on last week. So my point of call is to sort of do a high level look at the trust overall. What are our overall outcomes for every trainee together, and how does that compare to last year, and also how does that compare to our neighbouring trusts? And then a quick look at areas where I think we might need to have more in-depth look at the survey results, and a look at which areas, as you said, have done really well. And then I sent those off to medical and Director of Medical Education last week to say, these are my initial thoughts. At a trust level, they've got those already, so they'll be discussed, maybe raised at Clinical Senate. At some point, Mark, our Director of Medical Education, will present the outcomes at the trust leadership team, so they are sort of fed upwards into senior management.
Right.
The detail that I'm working through now, which is coming out to CMG, will also go to Clinical Director. And it's a starting point of a conversation, really. Were you aware of these issues? Is the things that are already in place? What needs to be? And then at some point in the next few weeks, NHSE will come back to us with what they want us. As a trust, we don't sit and wait for that, because we want to sort of start the process ourselves. So at some point in the next few, an email will come from NHS. The heads of school have looked at all your results and responses to the following. What are you going to do about the following? It will be the red flags. What are you going to do about the following? I will then continue the conversations I've started, because presumably the red flags I've been talking about with people will be the red flags that NHSE want us, and will formulate a response that goes back to NHSE to go back to the head of school, and they'll decide whether or not any further quality action is.
Yeah.
Does that answer your question?
Yeah, no, that's right.
Yeah.
I mean, I think it's important that people listening actually realise that there's a lot of scrutiny of these results. It's not something which is just kind of, oh, that's nice to know, and then parked. It feeds into, as you said, the senior management team within the trust. The medical director Andrew Furlong is, it cares about poor results in different parts of the hospital, and you often get, as an education CMG lead myself, you get your clinical director come to you and say, what's going on here? And, there may be pressure even above that from Andrew and the executive. So it is important. And it does, certainly when I've had to deal with it, I've definitely found it quite useful to bring some leverage to maybe things that you've wanted to do or you need to get off the, maybe you haven't got that buy-in, maybe it's not quite the right time. And that's been quite useful, actually. So whilst sometimes you can get these red flags and it feels like, oh, what can I do with this? It's a nice bit of leverage to get things over the mark.
It can. I think one of the things I find disappointing is that the fact that the trainees will have probably moved on before any put into place. So if a trainee's filled this in April, rotation is next week. And, we're still we've only just got the results. So by the time we've done all the things we've talked about, having conversations, setting up action plans, responding, if necessary, to NHSE and implementing change, the trainees who raise that have potentially long gone. So that sort of visibility of actually what we've done isn't always there, which is.
Yeah. So I see you. I guess to the doctors in training listening is that you'll be rotating onto potentially a different trust, but this process is, hopefully this sort of thing is happening at that trust, having had the last cohort of people provide the feedback through the survey. So I think it does lead to change, and we've certainly, over the last few years have gone through a process in ITAPs with one or two of our areas, and I think we're definitely better than we were. Probably like a lot of places that were, low morale, people not quite having the energy to sort of give to educate. having a set of poor results actually does sort of galvanise people. And yes, there is a grieving process to go through and the various stages. When you come out at the end of it, it does actually result. So do fill the survey out, even if it isn't mandatory, because it is something that we can use as leaders to bring.
I think a pattern that I've noticed over number of years that I've been working, it's just a sort of a symptom of the pressure that the workforce is under, that you fix things for one group of people and that potentially has a knock-on effect for another group of staff, trainees. So you might fix things for the foundation doctors, and then there's something you can see happening a year later. The sort of core level trainees are being impacted, and unfortunately, that's just a symptom, I think, of the pressure that is on the work. There are some space this year who across had pretty bad results last year, who've made changes with the help of their education lead, with the service managers and the sort of heads of, supported by the education team, and their GMC survey results are significantly better this year. So, there are success stories in there, which is good.
Yeah, that's good. I mean, I guess the big stick at the end of the day is if things are so bad, you potentially as a service end up having fewer training posts. I imagine that's the biggest kind of consequence of. Yeah.
Or you lose your trainees completely, which, is very rare, but it has happened and it does happen.
Great. Okay. Well, I'm conscious of time and I've got to let you get on and probably churn through some more GMC data. But is there anything else you wanted to raise, to mention on the subject of these surveys?
I was just going to highlight for anybody who does go onto the reporting tool that this year, I've just found it this year. So there is along the top bar, there's a link that says questions. And clicking on that shows you additional questions that all the trainees were asked. So outside of the standard set of indicators that we're used to seeing, there are questions on there about whether people have access to rest facilities, whether they've been humiliated, whether they feel as though there's any issues with sexual safety. And those questions you can look at by trust or by specialty, or by programme. So the thing to sort of just say, which I don't think we've said so far in terms of the colour coding, is once you get to 3 trainees or less, you can't see any results. So to protect anonymity. So if you see a square that's greyed out, it means there's 3 or less than 3 responses. So if you're looking at a very small specialty, you may not be able to get the information. But looking at those questions, which I say is on the top row of the reporting tool, shows you the additional questions that aren't included in the main reports.
Right. Okay. Yeah, that is useful actually.
So quite an interesting set of. There's things about burnout as well on there, and there is also a national summary report, which is quite an interesting read about sort of the very high level messages from this year's GMC survey.
Yes, and that will be a PDF document available on the GMC website.
That's on the GMC website, yeah. And I'm more than happy to talk to anybody with any specific questions or help out in interrogating information if I can help.
Absolutely, yeah. I think your sort of support over the years has been invaluable because of the complexity of some of this data, but also pulling in other sources of information as well. So I think if you are in a leadership position, whether that be in education or in management within your CMG, it's probably worth having a conversation with the Department of Education, either Joanne or one of her colleagues, just to try and understand this data a little bit. And you're there to kind of even spread ideas from different CMGs that you've worked with that may work in an area that's struggling. So that's sometimes, and that's what we hope to do with things like this podcast, is to hopefully share a bit of knowledge between some of the CMGs, which we're all guilty of working in silos occasionally. So
great. Happy to help.
Good. Well, thank you very much. Thank you, Joanne, for joining us today. I'll put all the links in the show notes to the various things that we've talked about. That will be the GMC, the reporting tool, and then the high level report as well. And of course, Joanne is available on the internal email address book, so you can contact her directly through that. But yeah, well, thank you very much, Joanne, for joining me.
Thank you. Thank you for inviting me.
And maybe we'll have you on at us.
I'll go back to the data.
Yeah, come very ahead of the data. And perhaps we'll have you on in the future at some point to talk about maybe some of the changes that have come about as a result of these surveys. So, but yeah, thank you very much.
I'd be glad to. Thank you.
Thanks for listening to the Faculty Focus podcast. If you liked the episode, please share with friends and colleagues. You can also like and subscribe to the show and perhaps even leave a review. Clinical education can be tough, but we're stronger as a community, so if you have an idea for an episode or would like to come on and talk to us, do get in touch via email or Twitter. Details in the show notes. The Faculty Focus podcast, Community Development Showcase.